Okay, the last part of this before we take a break is talking about video laryngoscopy. And one of the questions that's been asked is video laryngoscopy the standard of care? Should every patient that we intubate be intubated with video laryngoscopy? And this is a depiction of, potentially the progression of airway management. The first question is video laryngoscopy superior for trauma patients? And again, we're talking about this theory that maybe this is the way to go if somebody's in a C-collar. So this was a study that was done in the operating room, and they looked at stabilization of the C-spine, and they used fluoro. And so they had anesthesiologists intubate these patients. They had fluoro. They took a fluoro image at the beginning. They took a fluoro image when the laryngoscope was placed. They took a fluoro image when the tube was passed. And they took a fluoro image when it was done. And they did this with and without video. And what do you think the results showed? Less movement? That's what you think. But it didn't. There was no difference. There's the same amount of movement whether you use video or direct laryngoscopy. So no benefit of video for stabilization of the C-spine. So then let's look at which is faster. So if somebody's got a C-collar on, are we going to be more successful or are we going to be faster if we use video instead of direct? And so this was another study using a couple different devices, and it actually took 6 more seconds with video. Video was more successful for first pass success, but it wasn't statistically significant. That was in 120 patients. So added 6 seconds, it was better, but not statistically significantly better with video. All right, read the title of this article. So this article is purporting to talk about whether or not patients live or die based on which type of technique is used for intubation. So this basically, they compared direct laryngoscopy to video laryngoscopy, and they looked at death as the outcome. So, I mean, really, is it a big enough difference to cause death? Well, yeah, it turns out there is. So if you looked at the subset of patients with traumatic brain injury, it was double the mortality rate if the ED doc chose video laryngoscopy. So twice as high likely to die if the ED doc chose video laryngoscopy. And those are the numbers here. Why is that? Why do you have double the death rate for traumatic brain injury if you're using video versus using direct? No, these were great. It was well done study. Apache scores, they were matched very well. They did a great randomization. So here's a clue. So in all patients, it added 16 seconds video laryngoscopy versus direct laryngoscopy. Additional 16 seconds to get the tube versus direct laryngoscopy. And if you look at the traumatic brain injury subsection, it was additional 9 seconds. Okay, so what does that mean? What are the 2 things that we know double the mortality in head injured patients? Hypoxia and hypotension. So in this case, time equaled hypoxia. And if you look at the SATs, so basically the 50% of the patients in the video laryngoscopy had SATs less than 80% versus 24% in the direct laryngoscopy. So double the number of patients had SATs below 80 in the video versus direct laryngoscopy. And that ultimately was the difference. Essentially, the hypoxia resulted in a double mortality. Okay? So does that mean that we shouldn't use video laryngoscopy for trauma patients? What does it mean?
It means that probably when they did the study, the people using the video weren't fast at what they had.
Right. So what this means is that if you can't intubate somebody as quickly with the video as you can with direct laryngoscopy, then you want to use whatever you're faster with. And depending on our experience level and how we're trained, there's going to be a difference. And we'll talk about this study now, the novice versus the expert study. So this was a meta-analysis that Annals published, but it was originally published in a European journal, and it looked at, for difficult airways, it compared video laryngoscopy versus direct laryngoscopy for predicted difficult. And there ended up being 260 articles that they found. 11 of them met their criteria, ended up with about 1,200 intubations. They were all done in the operating room, all done by anesthesia, and their grand conclusion was that they were tied for success for difficult airway. There was no advantage of video laryngoscopy for predicted difficult airway in terms of overall success, but they were faster intubating with video laryngoscopy. And the take-home message was that video laryngoscopy gives you a better view. There's no difference in the rate of intubation success, but it was potentially faster with video laryngoscopy. So does that imply that this anesthesia group that participated in this study was more facile with video and therefore could do it more quickly? Probably. That's probably the difference there. Okay, so this is the real question. So what about every patient? Every patient that comes through the door, should our first attempt be with video laryngoscopy? And this is the novice versus the expert study. So the novice study, GlideScope showed up in this academic ED, and they brought all these GlideScopes in, and they had some coffee set up, and then they had some mannequins, and everyone could spend 30 minutes playing with the mannequins and using the GlideScope, and then they started the study. Okay, so interns were excluded, so it was second and third year residents and attendings were in the study, and they had their option to choose, but it ended up being pretty well matched between the two. And so this is the expert study. So in another academic ED that had been using the GlideScope for years, Stores came in with a CMAC and said, hey, we'd like you to try the CMAC and randomize patients to using the CMAC as direct or using the CMAC as video. The nice thing about the CMAC is you use the same blade for both techniques. So let's compare the results. So in the novice study with video, they were only 81% successful with their first pass versus 84% with direct laryngoscopy. So they were better with direct laryngoscopy, but it wasn't statistically significant. It took a lot longer for video, but video gave them a better view, but really that's not very important to us. So when they couldn't get the tube with video, what did the novice group use as their rescue airway or the rescue technique? So they couldn't get it with a video, what did they go to? DL, right. They tossed it, went to DL, and got it. So if you look at the expert group, they were 91.2% successful first pass with video, substantially significant difference between their first time success with direct laryngoscopy. Now that 84% looks low. We talked about we're greater than 99% effective. So this is just first attempt, and this is with second and third year residents being involved, and that's why that number's a little bit lower. So, and video laryngoscopy actually was better on difficult airways. So in the expert study, if they couldn't get it with video, what do you think their rescue device was? It was the knife. They went to surgical airway. So that was their next step. So big difference in terms of comfort level and strategy depending on whether you're an expert or a rookie. So